faculty presentation for the didactic component of our Session 3 ECHO. I'm very excited to introduce Kathleen Bernard. She's a family nurse practitioner. She's a cardiothoracic nurse practitioner at Northern Light Eastern Maine Medical Center. She spent 20 years as a registered nurse and 10 years as a nurse practitioner. She has worked in mental health field, primary care, and surgical offices. And today she's going to be talking to us about identifying and recruiting eligible patients for lung cancer screening. So Kathleen, I'm going to turn it over to you.
Hi, everyone. Can you hear me okay?
We can hear you great.
Yay. So next slide, we're going to talk about identifying patients. So the eligibility criteria, I think we know this pretty much. What we're following is patient ages 55 to 77, current smoker or former smoker. You know, we all know this, smoking history, equal to or greater than 30 pack years, healthy and showing no signs of symptoms of lung cancer like unintended weight loss or hemoptysis, not using antibiotics in the last 12 weeks to treat a lung infection. We find this scale, one of the things I think a lot of primary care finds challenging as far as current smoking history is the calculation piece, and that's the feedback we've gotten a lot of. I know some medical records have an outside link where you click and you go outside of your medical record to do the calculation. I think it can, I've heard that it's clunky. We kind of like this particular graph where it could be printed out and taped up next to the computer and just reference without having to leave the chart itself. Next slide. Next slide. Yay. So, you know, we felt that it was a two-prong approach. You know, educating the area providers and also community education and outreach. We've settled on this particular graphic to use with patients especially. We felt like it was easy to visualize, not too wordy, nice colors. So we like something like this. It's not overwhelming. And next slide. Just gonna go fast. Okay. So some of the things we've done so far, you know, our program is been for the past 5 years surveillance. So we've mostly, that's all we've done is surveillance, but we're transitioning to centralized, a hybrid kind of centralized, and I'll get to that in a minute. And so we've started doing education in the community. We did an education session, you know, come to for a meal, invited the community people. There was advertisements. You know, it was okay. I think that you know, we might reconsider how that was done if we did something like that again. It was not a huge turnout. We've got postcard mailers ready to be mailed out. We haven't done this yet. We're waiting for after the holidays to do that. We did attend the American Folk Festival in Bangor. There was a booth set up with a selfie station, and they ended up doing about 800 selfies. And let me see if you can see this. So they look something like this. People could pose in front of the flower lungs and, you know, get some information about getting screened. So that was nice. You had a good time. Yeah. We did, there were 2 newspaper articles and full-page ad. Oh, that's hard to see, but a full-page ad talking about the lung screening program here and about the merits of getting lung screening done. There were 2 television interviews, one with Amy and one with Dr. Klemperer. Again, you know, quick discussion of lung screening and our program, and then Amy did a radio interview, and we have a website. Okay, next slide. We're in the process of reaching out to the providers, going over everything, eligibility, the process of referring, sharing our program data. That was, when the program was first initiated in 2014, there was a lot of that done, reaching out to the local providers, different offices, everything from, Eastern Maine's primary care practices to outliers all over in our region. And that was done quite a bit in the beginning, and we really haven't done a lot of that, mostly because we've been transitioning to this centralized program. But that's in the works, to go out and start meeting with directly with the practices around us. There's so much confusion around this, and there is a lot of reticence, I think, in primary care, and various opinions about whether it's good to do this or not. And we every day see confusion from ordering providers about whether a patient is even eligible. We're always seeing that. So I think that it really is needed to go out and kind of reiterate what the eligibility requirements are. Next slide. We've got, we actually have two referral methods. Right now, again, because we do it both ways actually right now, even though we're not centralized. The document, both documents within the electronic medical record and paper that's sent out, faxed out to various offices to use, they do have the eligibility requirements on there. As Dr. Corson was saying, we've always had that part of our referral orders, but these documents right now are, now these will be referrals to the program.
Correct.
But the orders as they stand today, right now, are orders for CTs until we transition to centralized. So the intention is that those eligibility requirements will be on those forms. At this point, again, referring providers are responsible for putting the orders in, but also any kind of non-pulmonary findings. And we would continue to do that even as a centralized program. That ordering, the provider who refers to us when we become centralized will still be responsible for the thyroid nodule, the anything that is incidental. Next slide. So the centralized program is where the primary care, for the most part, would refer to this program itself, and we would then manage the lung cancer screening piece of it. We would do the shared decision making, order the scans, coordinate all of the next steps. We would do smoking cessation, obviously. We would basically manage that patient on this topic. It would not be management of COPD. It would be management of lung cancer screening and related items. The decentralized program is surveillance, basically, where we would, we're following this, and our radiology does the exam and the interpretation, but everything else really belongs to the referring provider, and we're following for data purposes. The hybrid program, which is really where we believe we're going, is we would be doing both. So there's a piece that, the way we see it right now is we will have set up a referral process coming into us. We would manage those patients, but we will remain the surveillance program for whoever feels they want to participate that way. So the providers within our system are not going to be required to refer to us. They can continue to order low-dose CTs, for themselves if they want to continue to be responsible for that. They don't have to refer to us, but we would track that data and be able to give that to them and report to the ACR and all of that. So that's it. I talked as fast as I could.
You did perfect. You did great, Kathleen. That was awesome. Thank you so much. You're actually a little ahead of time. You did.
Yes.